Hello, and welcome to this American Heart Association Go Red Talk on thoracoabdominal aneurysms, presented by Yale New Haven Health. I am Dr. Raul Guzman, Surgeon-in-Chief of Vascular Surgery in the Heart and Vascular Center at Yale New Haven Health and Professor of Surgery, Yale School of Medicine. Our vision is to enhance the lives of people we serve. This Go Red Talk is one way we can share valuable information so you can live a long, strong, and healthy life. Today, you will learn about thoracoabdominal aneurysms, which is an abnormal growth of the aorta, the largest artery in the body. Knowledge is important to good heart health, and this Go Red Talk will help to provide you with information for better cardiovascular health. I am happy to introduce today's presenter. Please welcome vascular surgeon Dr. David Kuyama of the Heart and Vascular Center at Yale New Haven Hospital. He is an associate professor of surgery and director of aortic surgery in the Division of Vascular Surgery and Endovascular Therapy at Yale School of Medicine. Dr. Kuyama.
Well, thank you, Dr. Guzman. It's a real privilege to be here today to talk to you about thoracoabdominal aortic aneurysms. If you're watching this, it's possible that maybe you or maybe a loved one actually has a thoracoabdominal aneurysm. And if so, I'm glad you're here, and hopefully I'll be able to shed a little bit of light on what exactly that means, some of the different ways we have to fix them, and some of the exciting new technologies that are really changing the landscape of how we fix this problem. So first off, what exactly is an aneurysm? Well, an aneurysm is basically a bulge in a blood vessel. Blood vessels are tubes that carry blood around the body. Normally, these tubes are straight and narrow, but if for some reason the integrity of the wall has degenerated, it can start to expand like a balloon under pressure. When an aneurysm has grown so large that the wall is thinned, then just like a balloon that's overinflated, it can rupture, which can be a life-threatening scenario. Aneurysms can happen in any blood vessel, but the largest blood vessel in the body is the aorta. The aorta carries all the blood flow from the heart. It rises and then descends in the chest, crosses the diaphragm, and goes into the belly. Along its course, it gives off branches to the organs like your intestines and your kidneys. Any part of the aorta can develop an aneurysm, but when the entire aorta from the chest to the abdomen is involved, we call it thoracoabdominal. Because these extensive aneurysms involve those critical blood vessels to the abdominal organs, surgical repair is quite complicated, and repairing them has been amongst the most challenging procedures that vascular surgeons like myself and cardiac surgeons perform. It's important to note that not all aneurysms need to be fixed. In many cases, we simply recommend surveillance and lifestyle modification with blood pressure control, smoking cessation, and anti-cholesterol medications to prevent growth. The primary factor leading to rupture is aneurysm size. And so if you have a small aneurysm, the risk of rupture in your case may be negligible. And in that case, it really shouldn't affect your lifestyle or your quality of life. But when these aneurysms grow and exceed 6 centimeters in diameter, we start to worry that the risk of rupture is becoming meaningful, and we start to think about offering repair. So let's say you have a thoracoabdominal aneurysm that's large enough that, say, you've met a surgeon and he or she's recommended repair. Well, what are the options? If we were having this conversation 20 years ago, there would really only be one option that we could discuss, and that would be an open thoracoabdominal aneurysm repair. An open repair is quite an extensive procedure. It involves making an incision that starts on the chest and goes down onto the abdomen so that we can see the entire aorta from where the aneurysm starts to where it ends. Once we have it exposed, we basically remove it and replace it with a plastic tube. We use a special tube that has some side branches that allows us to reimplant the blood vessels to the abdominal organs and maintain blood flow to them. In order to do this procedure safely, we work as a team with the cardiac surgeons and the vascular surgeons. It's a significant undertaking. There's no question about it. It's a good and a very durable operation, and we still do it today, not infrequently. But not everybody's a candidate for this operation. It puts a lot of stress on your body. Patients often require weeks to months to fully recover. And while many patients do make it back to their normal level of function afterwards, not everybody does. Some people suffer significant complications. It's important you be aware of that. Their risk of stroke, heart attack. Some people end up on dialysis. Some people even need a tracheostomy or a feeding tube during the recovery period. And almost everybody ends up requiring rehabilitation after leaving the hospital. So we really try our best to figure out who we think is a good candidate for that operation and is going to make it through okay, versus who we think it's best to consider other options instead. So what other options are there? Well, the exciting news is that over the last 15 to 20 years, our minimally invasive techniques and technologies have improved by leaps and bounds. Now, many patients with even the most extensive aneurysms can usually be fixed with minimally invasive stents. Sometimes the entire aneurysm can be fixed with nothing more than needle pokes. In other cases, we use hybrid techniques where some portions of the aneurysm are treated with open surgery and then the rest with stents. The real game changer has been the evolution of what we call fenestrated endografts. What's a fenestrated endograft? Well, an endograft is basically a waterproof tube that we insert into the aorta through a needle poke in the groin. It relines the inside of the aneurysm so that blood flows only through the tube and doesn't push on the wall of the aneurysm anymore. What makes a fenestrated endograft so special is that it has very carefully designed holes in it. These holes allow us to put side stents to preserve blood flow to the intestines, kidneys, and liver, while still preventing blood flow inside of the aneurysm itself. This technology has really evolved. Today, it's the majority of patients in whom we can come up with some kind of minimally invasive strategy to avoid the traditional open repair, with many people going straight home from the hospital in a day or two. It's really been a remarkable advance in our capabilities as aortic surgeons. Without knowing somebody's specific anatomy, usually from a CAT scan, it's impossible to say whether you or a loved one is or is not a candidate for these minimally invasive techniques. But it is important that you know about them and be able to ask your provider about whether you may be a candidate. On behalf of Yale New Haven Health and the Yale School of Medicine, I'd like to thank you for listening to me today. I hope I was able to explain some of the options that are available. Rest assured, while this is a very challenging condition, it's also curable. Thanks and be well.